Good afternoon, everyone, and welcome to the episode. I'm Jonathan Oleski with JMOR, and this is our virtual show brought to you by the Associated Jewish Federation of Baltimore and JMOR to keep Jewish Baltimore informed during this time of uncertainty. If you would like to ask our guests today questions during the show, please be sure to type them into the Zoom chat or via JMOR's Facebook page. You can message us. Now, it is my pleasure to introduce our two wonderful hosts, Beth Goldsmith, Chair of the Associated Jewish Federation of Baltimore, and Dr. Scott Rifkin, publisher of JMOR. Beth and Scott, take it away.
Thanks, Jonathan, and welcome everyone. This fall, as the weather cools down, the country has actually seen the number of coronavirus cases growing nationwide. Experts are becoming increasingly concerned about where the pandemic is headed over the next 6 to 12 weeks. Dr. Anthony Fauci has gone so far as to caution us about holding large indoor gatherings with guests for Thanksgiving. So what can we expect this winter, and how can we protect ourselves? How has the landscape changed over the past 7 months? And as we look ahead, what is the outlook for possible treatments and vaccines? Scott, please introduce our guest.
Thanks, Beth. I appreciate that. Jonathan Thierman, you've been with us before, and you were one of our, I think you're our first show. So thank you so much for doing that then and returning now. Dr. Thierman is the Chief Medical Information Officer at LifeBridge Health. He's the Chief Medical Officer of LifeBridge Health Partner. I'm not sure what that means, but you'll explain that to us. And President of the medical staff at Northwest Hospital. You were, as we mentioned, you were our first guest. So tell us what's happened since we spoke to you last. Give us a little update on the state of the pandemic from the perspective of LifeBridge.
Sure, and thanks for having me, Beth and Scott and Jonathan. It's good to be back. It's unfortunate that this book is becoming a theme of the show, but this is the times we live in, I guess. So I'm happy to keep our community informed about what's going on. We saw a great improvement in the positivity rate of tests that were being done in our state over the course of the summer and into the fall. And we saw the greatest factor that changed really was the death rate, the mortality rate in our ICU. So that's been a huge win, and both of those statistics are great for the prospects for the future. Unfortunately, as we move into fall, we are anticipating and we're starting to see a rise in cases in our state, not as much as in other states, but it looks like it's moving in the wrong direction. And there's a few reasons we can talk about for that. Some of them are social in terms of fatigue with mask wearing and with some of the other diligence we were doing. And some of them are biological with the changes in the humidity and the way our body can fight off infections and the way the infection itself can survive in the air. So several things stacked against us as we move into winter and fall, and we're starting to see a movement in that direction, although we're still doing relatively well. If you were to take a snapshot of today, we look very good compared to many states and very good compared to how we looked in May and June, but it not as good as yesterday and not as good as the day before. So in terms of what this means for LifeBridge, you mentioned a relatively new role I have as the Chief Medical Officer for LifeBridge Health Partners. And LifeBridge is divided into two main groups. One is the hospitals systems, and one is the commercial entities, such as our affiliations with nursing homes and ownership of nursing homes, outpatient pharmacies, Express Care, which many know is co-owned by LifeBridge, the urgent care chain. So a variety of businesses that are all healthcare related, and that's the LifeBridge Health Partners. It's about half our organization. So I'm now giving clinical guidance for LifeBridge Partners as the Chief Medical Officer. I'm still in my role with LifeBridge Health system for medical informatics and the virtual hospital. But what it means for us is, we're ramping up our testing capabilities right now. We're actually going live this week with expanded testing capabilities And one of the things that we're doing is we're testing across now multiple diseases, because as we move into the fall and winter months and people start getting cold and flu type illnesses, especially in children, where there's RSV as a third illness we worry about, a third viral illness. We now have difficulty differentiating between what's COVID, what's flu, and what's RSV. So not only are we expanding our capabilities to test more people, but we're also adding on to our tests, actually running it off the same nasal swab, but running other viral panels off the same nasal swab so that we can differentiate what someone's fever or sniffles are due to.
So very quickly, since you mentioned it, RSV, or respiratory syncytial virus, if I remember back from 30 years ago, it's been a long time for me. Talk about how that's different than what we're dealing with influenza or COVID, just quickly, so moms
Sure.
understand.
Yeah, I mean, it's mostly considered a pediatrics illness. And that being said, adults can get RSV, and we're actually testing. It's just easier logistically that if we're going to do COVID plus, we're actually going to do plus flu and RSV, whether it's an adult or a child. But the main implications are for children. It's usually seasonal and associated with mostly breathing difficulties, but you can also have COVID-like symptoms like fever and cough but you see a lot of wheezing children, sniffly, runny nose, wheezy children in the fall, and oftentimes it's RSV. The care for, there are things like Tamiflu that we can give for flu, and there are medications that are non-specific to RSV that are supportive to help with the symptoms. But mostly for most viruses in general, it's symptomatic support. The main issue with differentiating between whether it's COVID and RSV or the flu and COVID is simply the vigilance with which to isolate people. RSV also is contagious, but obviously the implications are far less serious than COVID infection and contagious.
And talk about testing for a minute. How long is it taking to get test results? I know in the nursing homes, it's still taking 2 to 5 days.
Sure. So there's been changes in testing, some positive changes. Number one, there's been studies that have shown that nasal swabs are as effective, as sensitive as nasopharyngeal swab. The nasopharyngeal is the one that's way up here. Some people feel it up here, but nasal swab's just the nostril, and depending on the nurse or the MA who's doing it, it's fairly much more comfortable anyways than the nasopharyngeal swab. Although when you tell a nurse for 6 months that they really need to go very deep, and then you say, oh, now you only need to go shallow, some of them still go a little bit deep, I've heard. So, but really the nostril is the evolution of the testing, and most places are doing that. The other major change or breakthrough, I guess, has been the predominance, the rise of antigen testing. And the antigen tests are the rapid ones. So those are the ones that the urgent care centers carry. And those are the ones that, frankly, anyone offering a 30-minute test or a 20-minute test is offering an antigen-based test. The antigen test is less sensitive than the antibody or the PCR test. And the antigen test usually will be a quick turnaround, but it's not as sensitive as a result. The PCR tests are still running 2+ days, and they're the gold standard, however, for testing. So the turnaround is better than it was, because when LabCorp and the other major labs were overwhelmed in the spring, you could see tests that took 7 or 8 days to get back, 9 days to get back, and that's really almost pointless, because per the CDC, at 10 days, you're past the point of worrying about contagiousness anyways, 10 days post-test if your symptoms are resolving. So I hope that the days of 9 and 10-day tests return around time are behind us, but still really the quickest that we've seen for the PCR-based testing, which is the better one, is about 2 days. And we consistently we do hundreds and hundreds of tests a day, and we're getting them at 48 hours.
Let me jump in. Let me
Yeah, go
jump in,
ahead.
Scott. I want to talk because I know that everyone in the audience wants to know. So what does this mean for the hospitals themselves? Are we getting filled up? Should people be wary of that? Is that another concern? And what about the safety of us going to the hospital for other issues?
Great questions. We are seeing an uptick in hospitalizations, and that is down from a peak in early May. Just looking at some of the state data where there was close to 2,000 COVID positive patients in the hospitals in early May. Now we're approaching 500. So we're at a fraction of what we were before. Again, a snapshot of today, there's no issue with capacity in the hospitals. There's no issue with ICU capacities. One of the things that I should say that's also improved dramatically since May is our knowledge, and it's almost, some of it's the science, but some of it's really the art of medicine, but the familiarity with the ICU providers with treating the disease is obviously we now have 6-8 months of experience, and so they're seeing a lot fewer ICU patients and a lot more early interventions that seem to be making a difference. So while we are having a slight uptick in the hospitalizations and the ICU beds, we're talking about going from a low of 79 ICU beds in the state to now we're at 116 today. That's an uptick. It's 20-30%, but it's nowhere near the 750, 800 ICU beds that we had before. So we're still at a small we still have a huge capacity, and we also learned, not only are we treating the disease more effectively in terms of the supportive measures, and giving remdesivir, giving convalescent plasma, and giving steroids to the patients, which are all advances that were made in the last several months in terms of treatments and are all improving outcomes and mortality dramatically, so as to not overwhelm the ICUs, even if the census rises. Not only are we doing all of those things clinically, but we've also learned some good lessons about preparedness. And frankly, we weren't as prepared as we ought to have been probably. And so we now have the ability to, at LifeBridge, for example, we opened up 100 extra beds across our system early in May to accommodate the surge. We never had a situation at LifeBridge, even in the height of this in the spring, and hopefully we don't get back to that point, but we never had a situation where we just didn't have a bed or didn't have an ICU bed either. We never ran out of ventilators. We weren't even close actually to running out of ventilators. We always had a buffer that was it was getting a little hairy at the peak, and we were hoping it would turn because we were getting close, but we never ran out. And so we've learned a lot, and I think that if we did have another surge in the winter, which to some extent we will have, it's just a matter of how high. We could easily, so those 100 beds have been converted back into the types of spaces they were for the most part. We could easily dial it back up and create that capacity again. So I think that we are better situated. Even if we got to the point we were at before, we're much better situated now for all those reasons than we were before. But my goal really is to, spread the word and help that we never get to that point, because I really truly believe, and there's people who don't, but I believe we're very close to having a vaccine, and very close probably means 3 or 4 months. Although we might hear in November that the Pfizer vaccine is approved for emergency use, but before regular people get it, it's going to be some time. But that's still pretty close, and if we can just kind of do everything we can to hold our ground that we've achieved, we'll save a lot of lives that way. So,
You mentioned 3 therapies that you think are helping, and there's been mixed research on those. Your experience of actually taking care of these patients, which ones really seem to work?
So I've talked extensively with our ICU team, who really do most of the clinical care, and they say that the high dose steroids, Decadron, daily has made the biggest impact. And, the truth is that it's hard to know, and we're not really interested in studying it academically, which ones. So everyone's getting the gauntlet, everyone's getting the kitchen sink, so to speak. Everyone gets all three, for example, and we don't know for sure, because we're not going to deprive someone of one of them if they're in the ICU, for example. We don't know for sure in our situation which one, but the thought is that the steroids are the most impactful. I've heard mixed kind of anecdotal evidence about remdesivir, same thing with the convalescent plasma, although it could be mixed because we don't test the plasma and we don't know if it's great plasma we're giving or okay plasma, or if the person who had the virus didn't mount much of a response and don't have a lot of antibodies in their blood. So that's really the least well controlled, I think, of the three medications in terms of trials, because it's not a medication, it's someone's blood product. And Mayo Clinic is doing a massive plasma trial that we partook in early. But like I said, I don't think they measured the plasma itself to know how much antibody was in that plasma. So it's a little bit of a black box, or a yellow bag, whichever the case may be. But the remdesivir and the steroids have been studied clinically, not in our situation, but outside, and they both show some positive effect. But the steroids was the most significant, I think, in patients that required were kind of pre-intubation or intubated but required oxygen for sure. The steroids had a 25 to 30% reduced mortality in that control arm. So that seems to be the biggest single step forward we took was in the results of the Decadron dosing daily.
And there were a couple of drugs that were politically thrown around. I noticed you didn't mention.
Yeah, they're pretty much out of the running. Those are ones that, frankly, like remdesivir, had maybe modest studies that showed modest improvements, but then they started to have studies that also showed negative impacts, and some, the risks did not outweigh, or the benefits did not outweigh the risks in some of those drugs. So we don't give those anymore. I don't believe Trump got those when he got his, the best of the best. I don't believe he got, I know he took chloroquine or whatever back in March or whatever, but what he got was basically what we give, as far as I know, plus he got an experimental monoclonal antibody, which those are really showing promise, and those really will be, that's the hope, that maybe those will be the bridge between the today and the vaccine to the general public, widely available. So, suppose it takes a year for every last person to get the vaccine. If the monoclonal antibodies, which are in phase 3 trials, and there's a couple of companies that are making those, including Regeneron, which was the one that Trump got. I think Chris Christie in New Jersey got a different brand of the same type of therapy. But what those are isolated, manufactured, if you will, antibodies that are, monoclonal, one colony, one specific antibody that's targeted specifically towards COVID. And so rather than getting a bag of yellow plasma that may or may not have varying levels of antibodies that are helpful for COVID, the companies have isolated one that works and multiplied it and have it in a controlled dose, and you actually know exactly how much antibody you're getting when you get the infusion. And so it's just a high-tech version of plasma donation, which frankly has been done for over 100 years, because we just didn't know what was in there, but there was something good in there that was helping us. So they did this a long time ago. This is a more sophisticated version of that. And I believe that will hold the most promise as a bridge therapeutic until vaccines are widespread.
And while you're speaking about plasma donations, so we're talking about people who have had the virus, who now have antibodies. What do we actually know? We hear a lot of talk about people getting the virus again. Can you share some insight into that, please?
Sure. So in terms of getting the virus again, there probably are people who've gotten the virus twice. I think it's a very small number of people, and these are case reportable episodes. It's, we've had millions of people around the world who've gotten the virus, and maybe, I don't know the number, maybe they've identified 100 people that have gotten it twice, maybe 1,000, I don't know, but it's really very, very tiny numbers. And in the few that they studied, they believe it was a second strain, that the virus was different enough from the first one that they basically couldn't fight it off a second time with the antibodies they had generated the first time. It may also be that some people just don't generate strong antibodies with lasting immunity. They might have an impaired immune system, so that the helper T cells, which are like the memory cells, which recognize, I saw that virus before, I know what to do, I can ramp up my antibody production. They might not have the best helper T cells. So there's a lot of factors that could lead to these occasional instances where people get the virus a second time. But for the most part, the majority of people who get COVID and recover don't, they shouldn't go out and expose themselves again. Obviously, they're not immune. And ironically, the president did say that he was immune to reinfection. And I was actually asked about that on Fox. And I told them, immune's a strong word. He certainly isn't immune, but he probably has immunity for some time. Ironically, the treatment that he got, which hopefully will be available for many others soon, which is the monoclonal antibody, seems to impart a much less long-acting immunity than your own immune response, because you're just giving the antibodies, you're not mounting that memory with those T cells, and so you can't mount the same immune response 8 months later, most likely, if you get this monoclonal antibody, as you could when you mount your own immune response. So it truly is a bridge in that sense. And when those antibodies run through your system and you flush them out, or they've been used up, you're not immune anymore. That's the thinking. Whereas in your own immune response, if you were to unfortunately get COVID, you would mount memory and you would be able to mount an immune response, except for the few individuals who got a second strain, we think. The vast majority of people would mount a robust immune response, most likely, and they most likely are even more immune, even though that's a very strong word, but they're more immune even than Trump probably is, but they're not Superman. They're still chances,
But for
Does
the
that
most
answer?
part, the stories of reinfection are sort of man bites dog stories.
Yeah, that's a
Yeah.
good way to put it.
Yeah, so think of it that way.
Beth, I have some audience questions.
Wait.
for you.
I want to point out that your dog appreciated that reference.
Yeah. I just let him out. Thanks.
We saw him walk by. It was cute. That was great.
I think Jonathan wants to jump in with
Yep.
some audience
Yeah,
questions.
we have some audience questions for you, Dr. Thierman. You were very popular when we started this half a year ago, and you remain so today. So this first one's kind of a long one. Dr. Thierman, as we recall, you are a parent, and as we go into the next 6 to 12 weeks, which is being reported as somewhat perilous, what are you personally allowing your children or family to do or not to do? Play sports, play dates. What about Thanksgiving with the family? What's your advice for our community here in Baltimore?
So my general advice is that we really shouldn't let up on all the things that we've done. So collectively, as a community, we've done a lot over the last few months that dramatically helped to reduce the burden of the illness. And even if we stayed vigilant with the exact same things we're doing now, we will see a rise, because as the humidity drops, the virus is thought to maybe last longer in the air if someone sneezed in a supermarket or something. And as the humidity drops, our own barriers to entry of the virus, such as our mucous membranes of our nostrils, dry out and get more susceptible to infection. And so, the bad news is, even if you do everything you have been doing, it's going to get a little worse, hopefully just a little. And, if we were to do more than we did before, maybe we could keep a flat line, a nice flat low, 3%. positivity rate, and we would be smooth sailing until the vaccine. But it's pretty hard to do more than we've been doing. And so my fear is as fatigue sets in with all that we're doing as kids, like you mentioned, I have 3 kids, and it's been a real challenge to have them in their school. It's a hybrid learning environment, so it's a couple days in, a couple days out, and the days, the whole thing is a challenge, frankly, for parents, I think, and working while your kids are home and all those things. My fear is that as schools start to do more, because they feel like they've been doing okay so far, we're going to see more outbreaks in schools. So as they do more sports, as they do more, as it gets colder and they have to eat lunch now inside instead of outside, that's my worry. To answer the question about what we're doing personally, we're vigilant. We, when they interact with other kids, they're wearing masks. They're not interacting with other kids without masks in the house. We have 1 or 2 families that we have kind of made a part of our pod that we've socialized with, and even when we're with those families, we like 90% of the time have a meal outside. I think in the last 8 months I've had an inside meal with someone outside of my nuclear family once. So it's been pretty strict in the Thierman household, I think, because I'm always the paranoid one in the crowd because I see the worst cases of what happens. So, but that being said, we still are having play dates with the kids as long as they're wearing masks when they're inside and they're separate inside and outside. They're not touching each other or the same, stuff because life has to go on too. And you have to strike that balance, and it's everyone's personal risk tolerance. I don't have any at-risk or elderly people in my household. So if you did, that would be a whole different equation, I think, in terms of what your risk tolerance is. So that's the line that I'm walking and everyone's walking, frankly. My biggest, and we're through most of the holidays, Jewish holidays anyways, but my big concern is the holidays. I think that we clearly, and I haven't said this on any sort of interviews with the media or anything like that, but in a Jewish setting, I'll just say I think we clearly saw some bumps in our communities based on gatherings and extended family visiting, even from out of state in some sense, in some cases around the Jewish holidays. And so and there's been clear ramifications, and I think that we just have to really call this year a different year and do something different with our holidays. We have Thanksgiving, and that's probably the next big holiday, I guess, that I can think of. So we just have to make sure we're really doing something different, because if we do it different 80% of the time, but it's kind of the normal thing on a holiday, that's going to be the super spreader event, and we're going to regret the laxity. So that's my biggest message, I guess.
Okay, and a second one real quickly, is asthma a pre-existing condition in and of itself is a real concern with COVID-19? Is the risk elevated if someone is asthmatic? An audience member wants to know.
Yeah, I definitely think it is. I'm not a pulmonologist, I'm not a pediatrician, but from what I've heard in my experiences, asthma, it's not a pre-existing condition like heart disease or some of these conditions of the elderly that really dramatically increase the mortality, I think. But that being said, certainly asthma, people who suffer from asthma have an impaired ability to clear their airways of even on a normal cold day, of mucus and other things. So they're in general more prone to infection, and when infected, in general more prone to worsening clinical condition than someone without asthma, because their airways just don't function as efficiently at clearing out mucus and bacteria. On top of that, it becomes challenging to treat asthmatics because there's some limitations depending on the setting to get nebulized treatments, because the process of nebulization aerosolizes their exhaled breath, and that poses a transmission risk. So, I know that kids at school whose school nurse typically has an ebb treatment for them if they get an asthma exacerbation in a cold fall day, won't give them an ebb treatment at school, or there's limitations. Maybe they can do it outside, but they can't do it inside, things like that. So a small part of it is some constraints on treating asthma, but yes, certainly a big part of it is the actual biological effects of asthma on the airways and the susceptibility of that patient population to infection in general. They get more pneumonia, they get more infection, period, and COVID is just another infection that they're more susceptible to.
Thank you.
Jonathan, talk a little bit about routine medical and dental care for folks, and whether, and break it sort of into the high-risk population and the regular population. What should they be doing right now?
So another great question. So truly the hospitals, people should not be putting off care. We saw the first second wave of this illness was all the people that put off care in the spring, and over the summer, while the illness was going down, the chronic disease implications were going up because people had not sought care for things that needed medical care. At this point, the policies are tight with all the health systems. The visitation is restricted. There's checking of everyone who comes in the door. I don't think that coming to the doctor's office or the hospital is the way someone's going to get COVID. It's having someone over for break fast is how someone's going to get COVID today. So the hospitals are a safe place to go, and the patients who have chronic diseases or concerning symptoms or acute chest pain or whatever certainly should go to the hospital. They are not going to get COVID that way. They are going to get something else they need that way. And the evidence of that, honestly, is just in the sheer number of doctors that I know that are on the front lines that are treating COVID patients every day, and the tiny fraction of those, less than the general population, who are getting infected themselves. So there's enough in place at the hospitals that people should feel safe that they're not going to be exposed, and they should get their conditions taken care of. So, yeah.
How about dental work? I get buzzed about once a week from my dentist to come in and get my cleaning done. I'm at high risk. Do I go?
I think the short answer is yes. I think the dentists are taking all the same precautions that the doctors are taking and wearing the masks, and I think that by the same token, I haven't heard of any dentists that have gotten COVID from their patients or therefore transferred it to other patients. I'm sure it's happened, but it's not a thing. It's not a phenomenon that's come to my attention. So I think the short answer is yes. Now, if and the dentist will hate me for saying this, but if there was a vaccine in a month and your dental cleaning was in 2 weeks, and you had a pre-existing condition, should you postpone it 2 months? Like, putting off a cleaning a few months is not going to have a big impact on your health the way putting off a heart attack a week would have a big impact on your health. So it's definitely something that you shouldn't. I think everyone's really taking a lot of precautions now, and these types of activities are safe to do, even if you have a precondition. I think that the dentists who are practicing are taking every precaution. So I think that it's probably fine. But it's a valid concern.
A little different question. I've heard folks say to me, I'm not going to get a flu vaccine this year because I'm not going near other people and I'm wearing a mask the few times I go outside. Talk about the importance of flu vaccines, not just for the patient, but from a public health perspective, that we don't tie up the system with flu when we could be directed at COVID.
Sure. And before I answer that question, I forgot one thing to mention about the last topic. All that being said, and all the reassurance I can give that it's not a dangerous place to be, At the same time, we at LifeBridge and all the other health systems have dramatically increased I can't not plug telemedicine. We are doing enormous amounts of telemedicine for those, in person is the best thing, but if you have apprehensions, there's an option other than just staying at home and not getting medical care. And that option is telemedicine. And we at LifeBridge since the pandemic started, we've done over 100,000 visits by telemedicine. At the peak of the pandemic, 45% of our primary care doctor visits across our system were done by telemedicine. That number's down to about 17% now, but still, 1 in 5 or so of our primary care visits are done by telemedicine. So the technology is come a long way. There's few things you can't do remotely, and it's certainly better than not seeing your doctor. So I would ask your doctor if they can do a remote visit if you have concerns about actually going in, rather than postponing a doctor's visit for 6 or 8 months. That being said, going in is still, the best, and I think it's safe. Sorry, I just want to plug
get a home dental cleaning kit with those little.
I don't know about teledental medicine.
By the telemedicine setup, that would be cool.
That's
Well,
not a bad
Scott,
idea.
I was going to just jump in to say, and this is a very personal response to that kind of topic. Anywhere you go, you get a vibe, whether it's a restaurant that you may feel comfortable in and another you may not. I feel very much that way I've had my dental hygienist do my mouth 3 times since this, whole horror has started. It's something that's important to me and important to my general health as well. And I felt very safe in that room and with that person. And I think we can't emphasize enough that we need to call out, whether it's a store, a nail salon, wherever, the places that are really doing an extremely great job, and the places that maybe are not. And if we show that by not only verbally telling our friends, but also with our feet, that we go where we feel comfortable, to me, that's just sort of common sense and brings the whole level of what people are doing to protect each other to a new place.
Absolutely.
But I'm a way bigger coward than you are. So it's.
But I'm an actually higher risk person than you are, Scott. Older and a cancer hopeful survivor. So lung cancer. So I'm just saying, I love hearing Dr. Thierman speak and talk about those things and having to be out there. I've been to Hopkins because that's where my oncologist is. And yet my surgeon is only doing virtual visits. So, it really is a mixed bag. And I think each of us has to take a breath, put on a really nice, safe mask, and go to where the safety precautions are in place.
Hey, Beth and Scott, Dr. Thierman, do we have time for one more audience question? Because I've got one that just came in.
I have time. I
Flu vaccine question too. Go ahead, John.
Oh, the flu vaccine?
Yeah, so do you want to answer the flu vaccine, then we can end with this audience question?
Sure. Was the question why I get it? Why not skip it this year? I'm not around people anyways.
Correct.
Yeah, there's good reasons to get it. I got it. My kids got it. And so I would say everyone should get it. I do believe we'll see a lower incidence of flu this year because of all the things we're doing to socially distance. In the Southern Hemisphere, whose flu season is over, the peak of it's over, they also had a much lower incidence of flu than normal. So why get it? If you get a fever or you get sick, and it were just the flu, you're going to go through a whole mental cascade of worry that you could avoid if you had the vaccine and you didn't come down with the flu. So there's a lot of peace of mind or unnecessary worry that you can avoid by protecting yourself with the vaccine. So it's just one more thing. If you can prevent all the other you know, in a typical year, most people get 1 or 2 fevers for other things. And so if you can rule those out and not get those, you'll save yourself the aggravation, you'll save yourself the unknown and the testing. And so I think that not getting flu is a good thing, and we should all get vaccinated. I will say that the flu vaccine this year, just because I want everyone to get it, but I want people to understand there's a higher incidence, it turns out a little bit this year because of the strain or whatever, of some flu-like symptoms the day or two after the flu vaccine this year. So, you know, so I didn't feel great on day 2. I felt 100% back on day 3, and I knew it wasn't COVID. I'm saying this only so when people get the flu vaccine, if it's like 25 or 30% this year have some sort of mild symptoms. And if and they can be very mild, you just don't feel 100%. But if you get that, you didn't get COVID 2 days after you got the flu vaccine, you got the vaccine, and there's some side effects that they go away right away. So, you know, most of the vaccination spots that I've heard of, or many great pediatricians and other places around town are doing outdoor vaccination clinics.
Through vaccinations, it's great.
What's that?
Curbside and drive-through vaccinations is really great.
So you're not going to get exposed in getting the vaccine, and it's going to protect you from worrying about, the last thing I'll say about it, and this is all hypothetical, but you can get two infections. So and one makes you more susceptible to the next. So you could get the flu and then get COVID, either because you're hospitalized with the flu and your immune system's battling the flu and you're more susceptible, or vice versa. You could get COVID and be doing okay, but then you get the flu and now you have COVID plus the flu and now you're not doing okay. So take the flu off the table and get the vaccine. And that's my recommendation.
Great.
All right, Dr. Thierman, how about our last question? This is from Shelley on Facebook. So is there any information regarding asymptomatic people as far as whether they're contagious or not, or is that inconclusive?
I think there's clear information that asymptomatic people do spread the illness. So ironically, regardless of your symptoms, there's a period of time that the CDC recommends you don't come in contact with other people. If you're asymptomatic, it's 10 days from your positive test. It's not 2 days because you're an asymptomatic person. It's the same 10 days because there's certainly cases of asymptomatic spread. By far, I'm willing to speculate, the vast majority of people who get infected from COVID get infected from an asymptomatic person on the day they were infected, who maybe half of those people get symptoms 2 days later, but everyone's asymptomatic until they mount symptoms. And so you don't know, if someone who's asymptomatic is asymptomatic and will never become symptomatic, or they're just asymptomatic today and in 3 or 4 days they will mount symptoms. So certainly people without symptoms spread the disease. That's pretty much how it's spread. Most people are not getting sneezed on by a person with a fever. They're, sharing too close of a conversation with someone who has no symptoms. So people without symptoms certainly spread the illness. But if you're talking about someone who tested positive and had never had symptoms, by the same token, they could still spread. And so they need to be quarantined for the 10-day period.
Thank you.
All right,
Great.
Scott, I think we have to wrap it up. Are you?
I know. And you know what's a shame about that, Beth? I probably have like 200 more questions for John.
Well, that's what I was going to say. And Dr. Thierman, we're going to have you yet another time on our show, I'm sure, because you are just, such an unbelievable source of information for us. And we're all so hungry for that information. So thank you for being here with us again. And we will look forward to saving some questions for as we move forward into the cold season. And hopefully winter won't bring more horror stories. I just want to remind everyone in our audience as we close the show today that in case you are living with your head in the sand somewhere, the election is 2 weeks away. So whether you have opted to mail in your ballot or you're planning to go to the polls, please don't forget to vote. And join us next Tuesday, October 27th at noon. We'll be talking with several local restaurateurs. We hope you visit associated.org and jmoreliving.com. There's lots of information, stories, and resources, and you can also sign up for the weekly newsletter. And until we meet again, I hope everyone stays well.
Thank you.
Thank you.